Hello, Michelle. This is Victor. Can you hear me?
I can hear you, Victor. Can you hear me?
Very well. I'm trying to get in through my laptop. For some reason, it's not coming through yet. So just give me a second. Nope, you're there. Okay, great.
Okay, good. Good afternoon. Oh, we've got lots of Brenda Rice today. We got 3 Brenda Rice.
I'll change my name.
Okay, no, I'm joking. Oh, we got 4 Brenda Rice. You know, you're the last of the 4 to show up, but a beautiful background. Okay, Jim. Thanks, Jim, for letting us know. I always appreciate your participation. There we go. Everybody's changing. All right. We only have 1 Brenda Rice now. The real Brenda Rice.
Yeah.
Good.
I say, thank God Jim Hummer knows me, so he knows it's me.
Okay. Hi, Darlene Shoemaker. How's life in the QIO these days? Get unmute. There you go.
Brenda, last meeting I changed my name to Brenda Rice for a few minutes. I don't know if you noticed.
Oh, I missed that, Jim.
Now, Karen Fleck is logging on right now. Please do not everybody make your names Brenda Rice. She's challenged enough to get everybody recorded. Maybe I'll change mine, see if she notices.
As long as I don't have to take all of your calls, I'm good.
Okay. You get extra CAB credit though that way.
Oh, there you go. Okay.
All right. Okay, so just again, so we have the most accurate registration we can. Please put your individual names and your facility in the chat box. And I know Karen Black is on. She is really not there in her island retreat, although I'm sure she would like to be. But she is in Baltimore County working remotely and making sure we have our registration up to date. So we'll get started in just a moment. And thanks everybody for getting logged in there. Okay. I'm looking for my future care colleagues and hoping they're all doing okay today. I know they've been busy. We have our first patient arriving as I'm starting this conference with high flow oxygen, COVID recovering and managed without intubation by using high flow. So we're excited to see a new technology in use. Do any of your facilities use high flow? Nasal cannula that delivers more oxygen and allows a little more pressure support without someone having to have BiPAP or a mask? I've heard some nursing facilities are beginning and some of the hospices are using it for severe dyspnea, but it is a new technology for me. So I'm excited to advance what we do here. Okay, let's go ahead and begin. I see Ryan there representing Canton, Future Care Canton. I see, let's see, I don't see North Point on though, and I don't see Julia Manor on yet. Am I missing anybody? No. Okay, but we'll go ahead and get started. Karen Black is on, so she will continue to take the individual names and your facility names. And Karen, I don't know if you can unmute or if you want to type in the chat box. Are there any emails from this particular cohort that you're being challenged? Do we have everybody listed here? These are our usual folks. I don't see anybody new here. So Karen, if you can put in the chat box if you don't have someone's email, just to be sure we're up to date. Okay, and with that, I'm going to start sharing my screen for today's session. And let me close a few things here and bring this up. All righty, we're at session 11 today, and so today we're discussing transitions in care. And before I review the literature, I thought we'd start today with a full discussion. I know the last few sessions we put a few 5 words or less in the chat box, but today we had planned last week that we would all have an example of a good transition and what in particular made it good. And then a transition where you felt there was opportunity to do better. And certainly in transitions, we talk about transitions from acute care to our short stay skilled nursing facility. We talk about transitions from the skilled nursing facility to the community. And we certainly talk about community admissions, particularly for long-term care. All of those are appropriate transitions. And if there's a transition that you want to talk about that I haven't mentioned, happy to do so today. So with that, I'm going to ask what's working. So let's start with the positive today. And we've got our usual cast of characters ready to talk. There's Julia Manor. Thank you folks for joining us. And who would like to start with an example of a transition that went well?
I can start, Michelle.
Great, thank you.
I keep saying I wish I had our physicians on this call because they're the ones that deal with this, you know, on the front line day to day. But I hear the feedback that comes back from the hospitals and from our team, so I can speak from a more global, comprehensive level. So I think our regular institution of the Interact transfer tool, as it has been revised and revised and revised with what the hospitals most critically need to make fast decisions, making sure that our teams, that is built into their workflow so they don't deviate from that, has always worked for us. We've added a couple more things on there. That the hospitals, primarily suburban, because that's our #1 hospital we deal with, has requested. All the feedback from RG Hackett and that team is great. They are never missing information. You know, we additionally send the MOST form as well as the last physician's progress note, maybe the H&P if they're a rather recent admission, and the MAR. And I've never gotten a call from the hospitalist or Dr. Park or anybody saying, you know, we can't properly take care of this patient because of XYZ. On the flip side, we've had some inconsistencies with discharge summaries. And I think the biggest hiccup for us is our primary nurse, who may not be a supervisor and may not be a manager level nurse, distinguishing the multiple discharge summaries uploaded into our electronic medical record. And they may say final, but they're not the final. And then another one comes and it says final. So they're reading meds to you or questioning meds that are, you know, two final discharge summaries ago. So we have to do more education with our nurses on looking at the date and the time of that dictation, because that really makes it the final one. And then cleaning up our EMR so that we eliminate those preliminary final ones from there to not cause confusion to the new teams taking over in the subsequent days. But as far as comprehensive discharge summaries from the hospital, everything's in there that we need. We rarely go into Epic to look into CareLink for additional information. They've done a really good job with that. And I'm speaking mostly for Suburban because that's who we deal with primarily.
Suburban did transition to our default summary, and they did help us with adding some additional information that from feedback from your facility, and they are using that now. So that's good to know. So what's going well is that you have a workflow for your skilled nursing facility in your nursing home, that when you feel the need to send a patient to the hospital for evaluation, you have a template in your electronic record that your staff use the workflow. In addition, you add very important information of the most recent progress note and the medication administration record So you've got a workflow that works for you.
Mhm.
And very good. Thank you. Thanks for getting us started.
Mhm.
Jared, how about you and your team there at Julia Manor? What is your what type of transition would you like to talk about? And it doesn't have to be SNF to hospital. It can be a different transition.
I echo the sentiments from Dr. Gill. I mean, we work in Epic a lot, and we've had a very solid communication flow with the hospital, and we've gotten all of our information that we need from them. So it's been a smooth transition for everyone that we're accepting. The biggest, well, maybe a challenge for us. I know we're working with the hospital about first vaccine efforts. That's been our biggest snag and our biggest frustration. We're trying to set up an effort with the hospital so that they can get their first dose of their vaccine, and then coordinate with us to get their second dose of the vaccine. But it's not necessarily answering your question, so I apologize.
Okay.
But
That's okay.
that's been our biggest frustration. I'll put it that way.
And do you have multiple hospitals that you routinely will be transitioning?
We have one main hospital that we transition with.
Mm-hmm. And which hospital is that?
That is Meritus
Okay.
in Hagerstown.
And they use an Epic system.
They do.
So, okay. And but let me just ask: does your electronic system communicate with theirs in any way electronically?
It does.
And tell us about that.
I mean, I don't know for sure. I don't know. I mean, I don't know the details, so forgive me. But I mean, I know it does communicate. So I don't want to.
No,
want to
that's
give you
okay.
a bad answer.
We're all trying to work through these things, and I know the University of Maryland's been working hard on working with point-click care to have an electronic flow of data. We here at Hopkins are using CRISP as the intermediary, so our discharge summaries, when electronically signed, go into CRISP, and the nursing facilities can access CRISP electronically. That's not quite the same as pushing things through. And we've been working with the CRISP team to push a medication administration record through as well. And we're working on it, but it's in pilot right now. But just curious if, Jared, is there anybody else in your facility who's on with you or that might know more about your electronic transfer of information?
I'd have to go grab them.
That's okay. No, that's all right. Just asking.
Sorry, I just started here a few weeks ago. I'm
That's
still
all
trying
right.
to get my feet under me.
No problem. No, I appreciate your speaking up and talking about these issues. So you've identified with COVID and our most recent management of COVID vaccine status and documenting the date of the vaccine and the manufacturer of the vaccine so that you can follow up as we begin to have workflows for second vaccines in this type of transfer. Good. Okay. I see Dr. Sheikh has joined us and working very hard in our transitions in care. And I'm going to ask, we're starting out on the positive note today, and we're asking for an example of a specific transition that you felt went well, something such as it doesn't have to be a hospital transfer or a SNF to hospital transfer. It can be a SNF to home, or it can be a home to SNF, whatever you'd like to talk about today.
Hi, good afternoon. Sorry, I'm in a facility, so I was trying to eat my lunch, so I do not have
No
my
problem. Can't take your mask off, take your lunch.
So multitasking.
Yep.
So are we talking about COVID specific patients, or could it be any?
Certainly COVID is relevant, but if there's a particular issue that's something that's front and center and a priority for you and your team, let's talk about it.
Yeah, I think as far as transitions, we have discharged many patients home. Some patients even after treatment of COVID. But we have seen that previously, because of the surge, which we are seeing again, over last few months, that the hospitals are discharging patients more so when they're still acutely ill. And that's certainly causing a lot of burden, and it's leading to a lot of rehospitalizations. I was just, talking to my team today, and then a lot of patients who are coming in anemic and may have had episode of bleeding but may not get enough workup in the hospital. So then going back to the hospital for anemia or for recurrent bleeding. So I think it's certainly a lot of work for our teams in nursing homes.
Mm-hmm. Yeah, that is something we're seeing here, where some of what we used to call more elective procedure, or things that weren't elective. So somebody came in with anemia, they may well get a GI scoping while they're here, particularly if they've come in with bleeding. And I've seen, because of COVID, if the issue can be controlled pretty quickly, that they may say, well, we can do that in a few more weeks, or it doesn't need to be this admission, and we have fewer. At one point, our GI suite was closed down except for emergencies because of using staffing to staff other areas of the hospital for COVID. So I think your points about, in general, the hospital stay may not have been as comprehensive currently under COVID, and some procedures that might have been done before are not done, and you're seeing those, in fact, leading to rehospitalizations. Okay, thank you.
We had a case here at Columbia just in regards to transitioning, kind of hit on a lot of different levels. So we have a sister assisted living facility next door. They had a patient who they were managing, pretty high acuity for assisted living, but they were making it work. Then the patient tested positive, and that kind of put it over the top of trying to manage then all those PPE requirements and a high acuity and an AL setting. So as of next door, we had a positive case already, so that we were staffing 2 for 1 resident. So we could certainly manage 2 residents. So we did transfer the resident over to the SNF for their observation period in the COVID positive unit. They remained asymptomatic, but had a lot of other health issues that they're dealing with. That they were here a few days, then they ended up in the hospital because of those other issues that they had. And then it was a matter of, okay, where are they going to be able to come back to? Was it going to be out of that observation window from when they first tested positive? So they were probably going to come here. We thought that was going to happen, but after with good communication with everybody and the hospital and the timing, they ended up direct admitting back to the AL because they were off of their observation for COVID positive, and they were actually admitted back on hospice. So we had the AL, the hospital, the SNF, the hospice, everybody involved in trying to manage this person through this window of observation and dealing with a lot of other clinically complex issues. So it was a good outcome.
Wow, that's a very good example of multiple transitions. What do you think are some of the reasons why it went well? Anything you could say, we've got to, we do this or that, or what made it go so well?
I think it was just good communications. Obviously, we have a good relationship. It's right next door, so we're really tight with our team next door and what their needs and capabilities are. We have a liaison at the hospital who manages well with the team over there, and we have a good hospice provider. So I don't know. It was just good communications. I think everybody was ready and willing to do whatever it took, and we typically don't admit new COVID positives unless they're ours. We're taking them back, but because it was next door, and it kind of is ours, even though it's not a SNF resident. So it was kind of a new one for us, and that's not something we usually do, but it worked out in that situation. Mm-hmm. So everybody trying to do the right thing and help each other. So.
Great. I imagine Hebrew Home, because you have multiple levels of care, you have found that works for you as well?
Yeah, same as Jim, we don't take new COVID from our hospitals unless they're ours, and we're not a CCRC, but we have 2 independent living buildings of 500 people and 1 assisted living of 60 something people. So if they're in our complex and under our umbrella, we make exceptions.
What about diagnoses? Any particular types of patients? We've talked a little bit about COVID and the challenges of transitioning with COVID vaccine information. Are there any other medical conditions you find particularly challenging in the transitions in care? Yes.
I don't know if anyone can relate, but given the advanced age of the elderly in Montgomery County, we get a lot of very, very old, very, very frail, mid-90s, close to 100, coming for rehab. And I know the doctors struggle with that, and our team, social work, nurse, everyone struggles with that. They've had multiple palliative care consults in the hospital before coming. They really do belong on hospice. They really cannot perform and do any rehab. And so I know, you know, from the clinical side, we have trouble trying to skill them and get them to come in and accept it. Once we do that, then it's just what to do. Therapists are struggling, medical is struggling, nursing is struggling, family is struggling. Some goals have been set at the hospital, and their palliative care team does, I know for sure, does a very good job, but it's difficult trying to have these conversations in the post-acute care unit where they should be more high functioning and performing at a faster pace. And we just don't know what to do with cases like that. And I'm finding that more with COVID over the last year, because I think the home environment is not adequate for them to return, and the hospital really doesn't have another disposition at the time. So that's challenging for our team, those cases.
I dealt with exactly the same thing yesterday. My vent admission is advanced age, was at home with COVID, but had private duty aides at home with helping the family, and the spouse died of COVID weeks ago. And the son in Philadelphia, when I called him to say, what should we do here, was like, well, mom's got to be able to do more now that dad's not here. I'm like, whoa, we got some work to do. And you know, my approach yesterday was to listen rather than to say, that's not realistic. I think we just need to establish, my approach yesterday was, let's establish a rapport. Let me understand where you are. I'll tell you where we are today, and we'll keep the dialogue open. But I share that struggle with you. There were some approaches in the last, but pre-COVID, a lot of folks were looking at care pathways, CHF pathways, COPD pathways, high-risk antibiotic pathways, substance use disorder pathways. So programs where the provider making the referral to the SNF, we were all working together with the same skill set and goals of care and how we do it. Anybody have any experience with that type of approach to transitions and whether it's been effective for you?
Are you referring to specific what, order sets or?
Sometimes people use order sets, yeah. That's one approach, yes, where the either the patients come from going into long-term care, but there's a community pathway that's CHF is managed and you get that pathway from the provider at the time of admission, or it's a hospital pathway or a home care. I know our own home care agency is working hard on a community transition for high-risk conditions such as CHF and COPD.
I can't say that our team, Michelle, uses pathways. I know we talked about this once with Suburban a few years ago, and they had wanted to launch a CHF pilot with a specific pathway. I'm trying to recall whatever happened to that. I don't think it got off the ground, but we don't follow any specific order sets or pathways for a disease. If they have a consultant they saw at the hospital who has a very specific approach to that management, they send that over, then that gets incorporated into their order set, but not a pick a diagnosis and here's 20 orders that populate for this. I know we have default orders for CHF with weights and when to call the physician if the weight is out of that parameter. But other than that, I think it's mostly triggers for abnormalities outside those parameters.
So you're describing a individualized approach for you, most likely because your patients have multiple conditions. While they have CHF, they also have renal insufficiency, and too aggressive a diuresis ends up with rehospitalization for acute kidney injury. So one of the challenges with the pathway approach that we certainly have found here as well. Very good. How about medications and transitions? Challenges with accepting a new patient and a med list and knowing what to do with it. In particular, we all know the regulations in skilled nursing facilities that require a diagnosis with a medication. There is no regulation in acute care. There's no regulation in outpatient care. And so we get our patients to the post-acute with a lot of medicines and not always sure why. Is that still a challenge, or has that been something that you found your systems are working through?
Here at Laurie and Columbia, and a lot of the nurses, when they send out and communicate to the doctors regarding their admissions, they put diagnoses next to the medications that they pull from the discharge summary, and the doctors do give them feedback as, yes, this is what this medication is for, or if not, this is what this medication is for.
Or perhaps we're not sure what this medication is for, and maybe we don't need it right now. Let me ask about antipsychotics. I covered the weekend here at Bayview and saw several dementia patients who were prescribed antipsychotics in acute care that were not on them at home. Several were being planned for post-acute rehab. How much of that are you seeing these days? Not at all?
I was on call last week and I called the whole week, all the admissions that came in. I can't say I saw any that had inappropriate Ativan or a new Seroquel order or something like that. So I don't know. That's just 1 week snapshot. I don't know if the hospitals are catching on to less use of these problematic drugs, but I didn't see any last week.
Good. Jennifer, how about you and your nursing team, and Brittany? Are you able to unmute? Jared, are they with you right now, or they're somewhere else? No.
Our tactical team is here.
Okay.
So they're with the tech team.
Okay. All right. And how about our folks at Canton? Ryan, anybody from nursing and you're on with you right now?
No, unfortunately, it's just today.
Okay. Dr. Shake, you get lots of folks from us. Are we doing any better these days?
Oh, I'm on mute. So I haven't seen any issues. Again, I'm not at North Point today, but I haven't heard of any issues.
Good. And in fact, part of what we did over the weekend for these patients was, in fact, work with our personal safety attendants. They did have dementia with delirium, falls. Both the patients I consulted on were falls at home, but cognitive impairment, clearly worsened behaviors in a hospital setting, severe hearing loss, and I'm happy to report we've just gotten some funding to give pocket talkers here in the hospital for older adults with hearing loss, and they're about $20 each, so they work. Actually, they work. They're not fancy, but they work. And the goal is that they can then transition to wherever they're going from acute care with that pocket talker. But it certainly, for me, made a difference in understanding some of the symptoms the patients were having. One lady had some significant knee pain after her fall that, while it wasn't a fracture, it was clear she had some injury there that we had to address as we were helping her recover from her injury. Okay. All right. Let me share some slides, and I know for some of you these slides are known, and you've helped actually participate in making some of these, but yeah. So this is our Maryland SNF to ED transfer form. It is not Interact. It is going to be uploaded in CRISP. I think my next meeting with them in a couple of weeks to understand where we are with the electronic transfer. It was updated to include COVID. It has not yet been updated for vaccine. And there were discussions at our last session. So we have COVID testing is now there. But not vaccine. And so that's a new update we've got to get done as well. Some of our emergency rooms across the area have been applying to be centers of excellence in geriatric medicine. And here at Bayview, their quality improvement project for their center of excellence application is looking at all patients who are coming from skilled nursing facilities into our emergency department and looking for this form and sharing some of the outcomes of using this form. So I was delighted that our ED reached out to us with this plan. Anybody using the form in your facilities right now that you can speak to use of this form? Or receiving this form back from your emergency rooms? Let me just stop.
I think the form that we typically use is the green sheet, Brenda, that we would use from Suburban, which is similar to this one.
Mm-hmm. Yes, your SNF collaborative down there made it green.
Yes.
Mm-hmm. Mm-hmm. But it is very similar. If it's not the same thing printed on green, I'm not sure.
It might actually be the same form, LaShawn, printed on our facilities green.
Good, good. LaShawn, do you get it back from the hospital ED when you have a patient that is not admitted to the hospital?
I'm sorry, can you repeat that again?
Do you see the forms returned from the emergency department when a patient is not directly admitted, but going from your facility, they go to the ED, they get evaluated or a treatment and come back? Do you see the form coming back completed?
You know, I would have to verify that. I'm not really sure. I typically don't see it. I know that form goes out on each of our nursing units. I haven't heard any communication that we're not receiving it back, but I could come back with an answer for you.
Okay, maybe next week we could do a quick follow-up and let us know.
Okay.
And we'll give some feedback to you, Suburban. I believe that they also are looking at the use of this form as a communication tool and looking at in their ED as well for their Center of Excellence in Geriatrics. So I think there's opportunity for us to collaborate in this.
I think it doesn't stand out for us, Michelle and LaShawn, because very few of our patients don't get admitted.
Okay. Because
I
you're
can't say that I've ever seen one of these come back, but we don't have a lot of people coming back.
back, yeah. So you're thoughtful about the folks you send, right? There's a positive. So they don't go out unless it's part of their goals of care and it's medically necessary. And so you don't use the ED for primary care, right? So, all right, that's fair enough. All right, let me go back to my screen here. So these are some of the changes we've been making, and I serve on the National EPIC Committee for Geriatric Medicine, and we had our monthly meeting at 11 o'clock today, talking about how we can do better using the tool of EPIC. So some of the basic things we did with our default discharge summary was basically just putting a phone number and a unit name so that your nurse on the night of admission can call someone if there's something missing, and the reminder of the care link there. But we all agree that care link in the night of admission, nobody's got time to delve into an electronic record, and so the information you need needs to be in the documents you receive. Standardizing some of the functional assessment and populating the advanced care planning module of EPIC. Our hospitals, the Joint Commission has begun to really crack down on hospitals documenting capacity. And in fact, they nearly shut us down last summer, summer before last, not last summer, the summer before last, because they found evidence that there were consent forms for procedures that were signed not by the patient, but by a surrogate without the two physician certification that that patient lacked the ability or lacked the medical decision-making capacity to sign that consent. And from that came a huge effort with EPIC to be sure the module within EPIC clearly had the documentation tools and then a quality improvement project to be sure it was being done and being utilized, and re-educating providers on how to do this. And so we now put this module, this data field, into the discharge summary. So the most recent capacity for that patient at the time the order is clicked for discharge populates the discharge summary. But Dr. Gill, you mentioned about multiple iterations of discharge summaries, and the other workflow piece we've been stating is that the order should be placed for discharge as the ambulance has arrived to transport the patient, so that the discharge summary, in fact, is refreshed at that time, and you have the most up-to-date information. So that is something that we've been working on, and I thought that we were doing better with that, but it is something I'll take back to our team.
Well, there's a caveat, Michelle, because I think in an effort to be more efficient with workflows, our hospital liaisons that are working at these hospitals and used to be stationed at the hospitals, but now are virtual,
Yeah.
They're also getting us those discharge summaries earlier in the day so that the teams can prepare and the physician can go ahead and start putting in some orders. So when the patient arrives, there's no delay in their pain medication. There's no delay in a treatment that's, QID, and they're going to need it as soon as they hit the door. So in an effort to be proactive, I think we may be getting
Gotcha.
not the final,
Okay.
which comes with the patient.
Okay.
And it's supposed to match up.
And then there's a workflow to make sure there's a final reconciliation there.
Right, supposed to be, yeah.
So my meetings with the CRISP team is that right now there is the ability to, at the time that discharge order is clicked, to then shoot electronically the medication administration record. So the last dose of pain medicine shows up electronically. So we're working towards some real time. Ultimately, what I want to see is it going from the EPIC right into your point-click care. For example, when I get a very complicated chronic vent patient from Johns Hopkins Hospital or Bayview, I actually get the full orders in EPIC Now, I can't just leave them there. I have to review them and agree with them or modify them or discontinue them, each order, but they're all visible on a screen for me to see the active orders at the time the order was clicked for discharge or transfer to my unit. And it's so much easier for me to sit and think about, okay, do I want that dose of furosemide, or is that kidney function a little worse today? Maybe I'm going to hold off today, than it is to type in furosemide and the dose. And we get so overwhelmed with what we're doing that having that ability to have data teed up for us electronically, to me, is a much more efficient and safer workflow.
So along those lines, Michelle, I remember our pharmacy, Omnicare, which is CVS owned,
Yeah.
and supplies, I'm assuming, a lot of pharmacy services to a lot of nursing homes. About a year ago, they talked about doing some interface with the hospitals where they could, the hospital would transmit that MAR directly to the pharmacy portal, where we could then verify meds, get the meds ordered before the patient even came to the nursing home, so that they'd essentially be on their way when the patient was on their way. And if there were some change last minute, then you just wouldn't put, you wouldn't click the final verify, activate that order and send the drug back.
Yeah,
But I don't know where that went.
Yeah, and people are still talking about it. It comes down to dollars and IT efforts to make it happen. Technology exists, and I certainly encourage all of us in the field to advocate for the resources so that we can do that. These are complex patients. These are the folks who are on multiple medications, and being able to have this type of data safely transmitted. There's lots of literature. I didn't bother putting it on a slide today about the number of medication errors made in transitions, medicines that are missed. There are 18 meds on the list, but you might miss 2 of the 18 when you're typing it all in or handwriting it as well. And was that 20 or 40 milligrams? So was it once a day or twice a day? So when you count all the potential errors that can be made in medication reconciliation, it's just not safe the way we currently do it, even if we are as attentive as we can be. But we still are, my last data still shows that we're getting majority of our admissions to the post-acute after 5 o'clock, certainly up till midnight. And many of them come Friday nights as the hospitals empty out. And so we've got multiple patients at once we're dealing with. We added ICD-10 coding, and we're working hard with our providers in the hospital so that the ICD-10 codes are accurate and specific, particularly documenting dementia. How often do we not put dementia on a diagnosis list, and yet we know there's higher reimbursement for our skilled patients who appropriately, where we code the diagnoses accurately with respect to dementia, delirium, and diabetes with complications. So, but our home care agencies are also being paid now by diagnoses, and our primary care practices are paid as well by diagnoses now. And so everybody recognizes the importance of being more specific and more comprehensive and finding ways to communicate all of that electronically. This issue has been taking my main time right now administratively, this advanced care planning. We know how much, or we know the efforts are happening in primary care to establish goals of care as we move toward the 4 M's of the IHI age-friendly system. And they're buried in annual Medicare wellness visits, but they're nowhere to be, and they're not easily found when a patient hits the emergency room or in acute care. We know palliative care is seeing more and more patients appropriately, and primary care teams are having goals of care discussions, but they're buried in progress notes and often not in the discharge summary. And we don't often send consult notes with our discharge summaries. And so how we make this advanced care planning module. So we spent a lot of time on our EPIC call this morning talking about different healthcare systems across the country and how goals of care and the 4Ms are documented currently in their systems, and how we might be able to transition that information out of that electronic record into the next level of care, whether it's a home care agency that doesn't run the same electronic record, or it's a skilled nursing facility as well. So, so we spent a lot of time in using data fields in our templates so that any progress note where there's been a goals of care discussion, just in that template, having a place to put it that then auto-populates into this module that then gets carried into the discharge summary. So there are ways to do all of this and building the systems right now. So we had a nice discussion this morning with the IT developers at EPIC to work on the 4Ms and particularly what matters and how we get goals of care discussions in our different settings of care, and how we get that information out and disseminate it. And then some simple things like, you know, we went from PICC lines, we no longer do x-rays for line placement here, but you need that documentation that there was an EKG and it showed appropriate information so that you can use the line. So we're pulling that, all of that's documented in our electronic record, but nobody thought it was important to the next level of care. So we've now told the EPIC team they've got to pull out the measurements for wounds, and they've got to pull out the PICC line documentation. And even something as basic as all the vital signs are well documented, including BMI, including pain score, including CAM. CAM is done every 12 hours. And so, and when the MOCA is done, all of these assessments get pulled in for the next level of care. The other thing we've been doing in transitions of care is educating on the transition. So patients and their families know what it means to come to an emergency room in a hospital, but they may not know what are the advantages of a skilled nursing facility. And so we've put multiple, in multiple languages now, a brochure on, and we modeled this after the Duke. Duke had a lovely brochure they hand out, but what we did was put it into our electronic record so that we can push it to family members through their surrogate MyCharts. And there's been a big effort for particularly our older adults to be using MyChart, but also to have a proxy in their MyChart. Those who got their first COVID vaccines were those that had the proxy and the MyChart access and could immediately sign up when visits were available. And then a video, and this now we actually have at the bedside iPads, and we certainly did even better when COVID hit and visitors couldn't be here in the hospital. So now these iPads are used for video conferencing with families, recreational activities in the hospital, patient education, including this video is available on the iPads for patients to and their family members push through MyChart to understand the transition. So we have a family member, a social worker, and actually a geriatrician talking about the transition from acute hospital to SNF available. So we're trying to do more with the tools we have, and particularly in this time of COVID, but ultimately advocating for an electronic approach to interoperability. This is actually something we're doing, trying to collect data on barriers to discharge. So our case managers now have a place in EPIC to actually document delays in discharge so that we can begin to collect data on these barriers. And it's not just SNF transitions, it's any type of transition, but understanding how we can do better at the time of discharge. Let's spend our last few minutes talking about experiences with telehealth. So I'm going to stop sharing my screen and let me go and ask anybody using telehealth in your transitions in care?
Here in Lorien, we have used it some for patients that come from the hospital and then they're to follow up with certain doctors for things that are non-critical. So instead of sending them back out for more exposure, we have used telemedicine appointments for their follow-ups.
And has that been a bit of a drain on your staff to coordinate those or to get those up and running?
It depends on the time. You know, the social workers are helpful. The managers have been helping and the nurses on the unit. So kind of we all collaborate together to get it done. So, but it has been challenging at times, but we felt that it was better if it was not needed for them to go to the office than risk exposing them.
Mm-hmm. Good. There'll be a session at our annual meeting of the American Medical Directors Association on different health systems and SNFs working together for telehealth programs. Duke is doing quite a bit of high-risk transfers from acute hospitals to SNFs and doing med reconciliation and warm handoffs through telehealth visits. And so they're going to be presenting some of their data. University of Virginia also has a program. We here at Hopkins have a telehealth program for our COVID grant. And what I'm hearing from our team, we have both pulmonologists and hospitalists available. And what I'm hearing is it's not being utilized. Now, COVID in our local nursing facilities has decreased recently, but not zero. I think one of the reasons it's being underutilized is it's not 24/7 access as I had thought when they set it up. It's really specific hours. And to me, when I looked at the hours, I said, you probably don't need the hospitalist or the pulmonologist at that time. There are other times you need them. And so I gave that feedback to the folks who were running that program that it's probably not being utilized because it's just not meeting the needs of the folks caring for the patients.
It also hasn't been rolled out completely yet. We're still working on that and getting credentialing done.
Well, I know when I call the Hopkins Access line, I have to go through a telephone tree that says if you are calling from a skilled nursing facility regarding a COVID visit, please push this number. So they're ready for you. But glad to know that, Diane. Thank you. All right.
I think the, excuse me, the other piece of that would be once a relationship is built, because a lot of patients, you know, what if they were to get sick in the middle of the night or in the evening, then is there an open line of communication so those patients can be kept in the facility and we can avoid those hospital transfers? So I think that's where hopefully we can make a difference. So I'm hoping as the program is rolled out and then relationship is built with the hospice team, we can expand it to other hours as well. I think that will be certainly beneficial.
Good. All right. I'm going to ask Dr. Victor Bogoslavsky for any comments regarding from the IHI, a quality perspective on transitions in care and safe transitions.
Well, thank you, Michelle. I'm great to be as always just learning and taking notes. You know, it looks to me like the sort of we have more what is working well rather than challenges. So it seems to be the processes are pretty well set and are implemented. But I was just wondering from the IHI as always and the quality improvement perspective, if someone can speak a little bit more about the use of data to guide quality improvement initiatives, like where you see potential gaps. You know, there were some comments made about the discharge from hospitals to the centers and puts in pressure with residents coming back. How do you use data to look where the issues are, and particularly how do you plan for for changes and for planning for improvements really? So that might be if someone could speak would be great. If someone is willing to speak next week early, I mean, as a follow-up, that would be also good. Your example, Michelle, about the documentation and the electronic medical records and using the data is such an excellent example. You wonder how much that can be used by other centers. You know, I guess my more take about the data, like looking at the data and to guide the improvements if someone would be willing to.
Well, I bet everybody in this call looks at rehospitalization rates and ED rehospitalization rates and uses that as a quality measure. Yes?
Okay, they do.
Yeah, I can comment a little. We rely a lot on our quality department, and we identify our PIPs based on some of those quality metrics that we feel we need to improve. I can tell you that we have priority projects every year that we develop during the previous year. And so specifically around this and quality, our priority projects for 2021, which fall to myself and the other Brenda Rice, is the 30-day readmission rate, because that's obviously part of our, one of the quality metrics we get graded on and rated on, and that. And then a new one that we're tracking this year is our pressure injuries, both for long stay and for the short stay. So those are two of our quality measures that we track on a monthly basis and report out to QAPI on a monthly basis. And then based on how those fluctuate, you know, is where the process improvement projects come in, and we develop those. And for the rest of the year, we'll be working on those process improvement projects. So that's, I don't know if that answers your question, Victor, directly.
It does. Yeah, I mean, it's like I'm tending to ask another question, if I can, about how do you look at the process? Do you bring the team together, you know, review the processes, process mapping?
Yeah.
Any tools that you're using, you know, to guide your sort of thinking about the improvement? Thank you so much.
Our quality department takes the first deep dive into analyzing the metric, and where the changes are coming from. And then it all escalates up to QAPI. And it's really in QAPI that we have that multidisciplinary discussion for that one particular quality measure. And dietary will weigh in, MDS will weigh in, obviously nursing, medical, even administration. CEDIA obviously plays a big role from infection control. So it's from there that it develops. And then we may have a smaller task force working separately on that one PIP that works at the individual unit levels where we identify the problem is. It may go off in a different direction where we find that two particular units are having an issue with this one aspect of this quality measure. And so then focused education is done on those units around that particular topic, all 3 shifts, that kind of thing. So it depends on where the data shows that the issue is coming from, and it may be different areas on different units. So then it becomes very individualized education.
Great, thank you. And certainly we all have our quality surveys that where we have to show our quality improvement projects, our data and our action plans. Perhaps maybe we could start next session talking about if there is one related to COVID that anybody has. Also next time we're going to be talking about safe visitation and reopening. Talk about a positive for all of us. And I know, quite frankly, it's a little premature here in Maryland, but let's be positive and let's start planning for it. Let's have a discussion of initiatives you're thinking about as you're planning for those revisitations. I will say we've had the luxury being in on a hospital campus and being a chronic hospital rather than a SNF. We have begun to do visitations, and I'll share a little bit of our processes with you next week. But think about what as you're talking about these visits, and when you're doing your visits for end-of-life care, how is it that you're doing them safely? So With that, I'll say to everybody, have a safe week and happy week, and I'll see you next week. Thanks so much. Bye-bye now.
Thank you. Bye-bye.
Bye.